Welcome everyone. Xin chào mọi người. We'll begin. We have two cases to discuss, and they're very interesting cases tonight. One from
Vâng,
the ovary, one from the bowel. So hopefully we can find some interesting things to talk about with those. So Dr. Lin, I'll let you present the case, the first case that you want to discuss.
Let me some. Yes. Mọi người đã nhìn thấy slide chưa ạ? Rồi.
Rồi chị ạ.
À, thì cái ca thứ nhất là em xin giới thiệu là cái ca thứ nhất là một cái u ở ở hõng tràng. Bệnh nhân này nữ 46 tuổi. Cái kích thước u khá là to. Kích thước u khoảng 7 cm, đường kính 7 cm. Thì nó nhìn cái hình thái thì nó giống một cái u của cái mô đệm của đường tiêu hóa ấy. Thế nhưng mà nó có cái đặc biệt rất là đặc biệt là có rất nhiều cái sợi collagen.
Em chưa thấy cái slide đâu chị Linh ơi.
Ờ, đây. Thế chắc là đợi chị một tí. Zoom mình đang bị lỗi ở đây. Sorry. Đây. Thế là đây là cái u ở hõng tràng. Đấy, nó nằm ngay ở dưới cái lớp cơ của hõng tràng đấy, nó cũng gây biến đổi cái lớp cơ. Nhưng mà nhìn thấy cái đặc trưng của nó là nó rất nhiều cái sợi collagen và nó dày, giống như là cái sẹo lồi mà mình vẫn thường hay gặp ấy. Mà không biết là các bác sĩ khác có gặp cái trường hợp những cái sẹo lồi này. Thế đấy thì là những cái bó sợi collagen dày màu đỏ đấy. Thì zoom lên thì thấy slide chạy rồi đúng không? Đấy, Hà thấy chưa? Vì cái chị đang chạy 3G nó hơi bị giật. Với những cái bó sợi collagen nó dày hẳn lên như thế này. Trong khi là cái thành phần tế bào hình thoi thì nó lại ít hơn. Là chủ yếu là cái nhìn thấy cái đặc trưng của nó là giàu collagen, giống với sẹo lồi thể coi nó ít đấy. Thì cũng đã nhuộm hóa mô rồi, trường hợp này thì cũng nhuộm hóa mô rồi thì nó đã âm tính với CD117 là của cái u mô đệm dạ dày, là âm tính với cả desmin cả S100. Thì mới nhuộm có 3 cái marker ấy thôi, còn khi 67 thì rất là thấp. Đây cũng là cái hình ảnh là một cái vùng khác. Thì cái phần colloid ở bên dưới, những cái phần phía trên thì nó cũng giàu cái thành phần tế bào sợi, nó mảnh thôi. Đó là những cái tế bào hình thoi này rất là mảnh. Ờ, ờ, Kích thước nhân cũng nhỏ, và bà Tương bà Tương thì cũng ít, và nó ranh giới các tế bào nó cũng khá là rõ. Thế phần này thì cái phần colloid thì là ít hơn. Thì trong cái trường hợp như thế thì có mấy cái khả năng có thể xảy ra, đó là một cái thứ nhất là lúc đầu tiên ấy thì cũng nghĩ đến là một cái u mô đệm dạ dày mà có cái tăng sinh cái collagen. Thế trường hợp thứ hai nữa là cũng có thể là một cái tổn thương ờ, sơ bì sơ bì đấy. Thế nhưng mà cái tổn thương đấy thì nó nằm ở da, thì bây giờ câu hỏi là da là liệu nó có thể là đường tiêu hóa hay không, desmoid fibromatosis ấy. Đấy thì không biết là là nó có cái khả năng xảy ra là cái trường hợp đấy không, vì nó đây là ở đường tiêu hóa. Thì, đấy là hết cái ca thứ nhất rồi ạ. Professor, please give me some comment about this case.
Yes, so this case is brings the differential diagnosis of uh, spindle cell tumors in the GI tract. Of course, there are a variety of things that we see, but I remember a presentation by Elizabeth Montgomery who's a GI pathologist of some Neuding. And she talks about recognizing the levels that are involved with the tumor. Um, the tumors that involve the wall of the GI tract and destroy muscle are essentially, or displace muscle, are of two types. The most common one, of course, is the GI stromal tumor, um, which we could see in this location. It's not common in the small bowel as it is in the stomach, for example, but it does occur there. And so GI stromal tumor is a possibility. In general, the pattern of growth with GI stromal tumor tends to dissect and separate the smooth muscle. In this case, we don't really see what the margin looks like between the tumor and the surrounding smooth muscle, other than that we can see that it has destroyed and extended up into the submucosa almost of the mucosa of the surface of the interior surface of the bowel. So that's one tumor that is commonly seen. Um, uh, the other tumors that are seen include glomus tumor, which can also have a lot of very sharp spindly cells, but tends to have slit-like spaces in between the spindle cells. And sometimes that tumor can involve the mucosa and even be mistaken for a neuroendocrine tumor because the nuclei may be very low grade and round. In this case, the nuclei are low grade, but they're very spindle shaped. So we might be thinking about things like a schwannoma. Those again are uncommon in the primary bowel, but we can encounter them. Um, the presence of these dense collagen bands would be unusual in GI stromal tumor. It would be unusual in schwannoma and would be unheard of in glomus tumor. So we then come to two other lesions that can look somewhat similar, um, but tend to have a different level of involvement in the bowel. So one is inflammatory myofibroblastic tumor, or IMFT, as we sometimes abbreviate it. And that is a tumor that generally does not violate or invade the muscle. It may butt right up against the muscle, but it's usually in the adventitia serosa of the bowel rather than within the muscle wall. It also can have very low-grade spindle-shaped cells, and we call it inflammatory myofibroblastic tumor, but the inflammation can be quite sparse in that tumor. Many of them, probably a majority, will stain with ALK protein because they do tend to have an ALK mutation that's involved with them. And then I think the last lesion that I think of in this category is fibromatosis. And fibromatosis is a lesion, as you know, that is usually in this location related to a mutation in the APC gene, which is the same gene that oftentimes is involved with the development of mucosal polyps. So in this patient, they're still fairly young. Developing a fibromatosis or a desmoid tumor like this in the bowel would lead me to want to either make sure that we had endoscoped and seen that they did not have any polyps, or potentially do genetic testing to see if they carry an APC gene mutation. And doing that has a couple of purposes. One is it alerts you to their subsequent risk of gastrointestinal and a few other tumors that are APC gene related. But it also alerts you to see what their family history is and whether other members of their family may have a similar mutation that could put them at risk. As you know, the manifestations of APC gene most commonly, or APC gene mutation most commonly, are in the bowel mucosa, where they will get an abundance of adenomatous polyps, usually in the colon, but sometimes also involving the stomach, sometimes involving the ampulla of Vater, and making them prone to upper GI tumors as well as lower GI tumors. So those are my main considerations in this. There might be other spindle cell lesions that you could see in this location, but I think the most likely diagnosis here, based on the morphology with these low-grade spindle cells, these dense collagen bands, is that of a fibromatosis or desmoid tumor. And usually I would confirm that with a beta-catenin stain, looking for nice nuclear positivity. However, it's not true that every desmoid tumor will show positive beta-catenin. And so when we see them in, an extremity or other locations, if they're beta-catenin negative, we might proceed to do genetic testing on those cases to look to see if we have the CTNN1B mutation as well. So those are my thoughts about this case. Differential diagnosis based on location and based on the degree of penetration in the wall, involvement of the serosa versus involvement of the muscularis. And then, of course, your immunohistochemical staining can be useful. I'm not aware that there's a good substitute for beta-catenin staining other than doing the molecular testing for CTNNB1 mutation status. Although obviously in this patient, considering APC mutation, which would be a precursor molecular change to the CTNN1B, would also be potentially helpful. So any questions or further thoughts on that case?
Professor, this tumor will need accessory stain with beta-catenin for diagnosis.
Yes, I think ideally you should do that stain because a positive stain will help you to verify that that's what it is, and you're not dealing with a inflammatory myofibroblastic tumor or something like that.
Yeah. Thank you. Có ai hỏi câu hỏi khác được không? Nếu không có ai hỏi gì thì em chuyển sang ca thứ hai nhé.
Okay, go on to second case.
Ca thứ hai này cũng khá là khó vì bệnh nhân này bệnh nhân của Hà đấy là một cái bệnh nhân có cái u buồng trứng một bên bên phải thôi, bệnh nhân nữ 50 tuổi, và cái hình thái khối u thì nó là độ cao, nó là tế bào nó rất là ác tính. Nhiều vùng thì nhìn như là như là biểu mô ấy, thì không có cái hình thái nào mà nghĩ đến một cái sarcom hay là một cái cái u tế bào mầm. Tuy nhiên là đã nhuộm với rất là nhiều cái marker để khẳng định cái loại u của buồng trứng, như là WT1, B16, BAT8, CDX2 với B63, EI đều âm tính. Và tiếp tục theo ngược tiếp là những cái khối marker của dòng mầm thì cũng đều âm tính. Đây là những marker mà hiện tại đã có ở khoa, thì còn một số marker khác thì cũng đặc hiệu hơn cho dòng tế bào mầm thì mình không có nên là không nhuộm được. Thì tất cả đều âm tính, chỉ duy nhất có một cái dấu ấn K5.2 là dấu ấn gợi ý biểu mô đấy thì nó dương tính. Thế là trong cái trường hợp này thì đây là cái hình thái khối u. Nên cũng chưa biết là chẩn đoán là gì. Ở phía này là phía vỏ của khối u, thì cái tổn thương một cái khối u khá là lớn và hoại tử u thì nhiều, trong đó khi thì hình thái tế bào khối u thì khá là ác tính. Độ ác tính cao vì khi chúng ta sẽ nhìn thấy là cái nhân atypical, cũng như là có rất nhiều cái vùng hoại tử kích thước nhỏ đến lớn, rồi mật độ nhân chia cũng khá là nhiều và đưa lên cái hình thái lớn hơn. Đây thì chúng ta thấy là kích thước tế bào không đồng nhất. Thứ hai nữa là tế bào nhân thì méo mó và một số thì hạt nhân khá là rõ. Thế, trong khi cái phần bảo tương của tế bào ranh giới thì các tế bào này cũng không rõ ràng. Thì mật độ nhân chia chúng ta cũng có thể đếm ở, cũng thấy là khá nhiều nhân chia ở trong cái slide tiếp theo. Thì đây cũng là những cái ổ hoại tử xen lẫn đấy. Nên mật độ nhân chia ở đây chúng ta có thể nhìn thấy là 4 đến 5 cái nhân chia trên một cái vi trường. Đây chụp ở bán kính 40. Nhìn hình thái thì ác tính như vậy, nhưng mà hóa môn miễn dịch thì chỉ có mỗi cái dấu ấn K5.2 dương tính thôi. Còn là cái bát tám này là cũng âm tính, thì chúng ta có cái nội trứng này, cái số cái tế bào còn sót lại của buồng trứng thì nó dương tính. Thế còn tế bào u thì nó âm tính. Dấu ấn bát tám này là chỉ ra cái nguồn gốc của buồng trứng. Thế nhưng mà nó lại âm tính. Thế trong trường hợp này thì em vẫn nghĩ đến một cái ung thư biểu mô không biệt hóa của buồng trứng. Undifferent carcinoma in ovarian. What about you think this tumor, Professor?
Yes, this is a very difficult case. And it brings up many teaching points about stains and sensitivity and so forth. So let me share the slide from my side of things. As I had thought about this case, there are, I think you've considered in the differential let's see, make sure I've got the right tumor here. The variety of different types of cancers that we can get in the ovary. So we have the common epithelial tumors, which would include, of course, serous carcinoma, endometrioid tumors, and some non-endometrioid tumors. And those should all be PAX8 positive. There are the mucinous tumors, which can have large glandular spaces and may be negative for many of the conventional markers of ovarian origin, like PAX8 and so forth, CK7. But this tumor doesn't have any of those features. It does have somewhat clear cytoplasm, eosinophilic cytoplasm, lots of mitotic activity. And it does seem to have a little bit of epithelial clustering, maybe, to these cells. But it's negative with all of your conventional epithelial markers. except for the CAM 5.2, which can be seen in some cancers and also some other neoplasms, both smooth muscle as well as a few other tumors of that sort. The nuclei are pretty high grade. You have areas of single cell necrosis, some pleomorphism to the nuclei. And so this looks like a tumor that could have arisen in the ovary, but what are the tumors that can lose markers or that can begin in the ovary but not stain with PAX8 or WT1 or these other usual markers if they're carcinomas? Well, there's one tumor that usually derives from endometrial type tissue that is the undifferentiated carcinoma or dedifferentiated carcinoma, which very frequently will lose hormone receptors. It will not have PAX8, and it may lose keratin as well. So it can just look like a very undifferentiated high-grade neoplasm. However, it doesn't look like this usually. This has much more cytoplasm and clear spaces and so forth compared to that tumor usually. It tends to look more like a lymphoma, like a high-grade lymphoma almost, with just syncytial type growth, very large high-grade nuclei, and relatively scant cytoplasm. Now, could this be a clear cell carcinoma? So that's a possibility as well, but clear cell carcinomas don't tend to lose their cytokeratins. They don't tend to lose PAX8. And so I don't think this is a clear cell carcinoma. The one thing that might make us wonder is that there does seem to be a little bit of some eosinophilic droplets or something in a few cells, like right here, maybe one here, that could be seen in clear cell carcinoma, but I don't think clear cell carcinoma fits this very well. So for most of the carcinomas, I think we can put that aside, and I don't think this is any of the usual common epithelial tumors. So then we look at the sex cord stromal tumors. Well, it's very true that sex cord stromal tumors don't often have keratins. They may not express WT1, or they may only weakly express WT1. There are other stromal markers like MART1, calretinin, inhibin that can be expressed to varying degrees, but we haven't stained for those other markers. The only sex cord stromal marker in the panel was WT1. And as I said, that is not a very sensitive marker for sex cord stromal tumors. That said, this is, again, very poorly differentiated. It's not forming tubules. It's not forming, granulosis type follicles. And so poorly differentiated sex cord stromal tumors are very uncommon, even more uncommon than the majority of sex cord stromal tumors. So just statistically, I do not think this looks a whole lot like a sex cord stromal tumor, but I can't entirely exclude that. And so I would want to do other markers like inhibin, MART1, and so forth, maybe calretinin, to just see if there's anything that lights up in this tumor that might give it away as a sex cord stromal tumor. If it is a sex cord stromal tumor, it's a very high grade one, poorly differentiated. it's going to behave like a malignancy, and so that's a concern. The other category that I think we need to think about are sort of primary sarcomas. That would include things like endometrial stromal sarcoma. This is not a well-differentiated tumor, so it's not in the well-differentiated stromal sarcoma. But some of the high-grade endometrial stromal sarcomas can have areas of necrosis. They can have myxoid areas that could correspond to some of these type of areas. We have continue to find new fusion gene or other mutational markers for the high-grade endometrial stromal tumors. The only immunohistochemical markers which we have that might be available, I believe, to you would be CD10, which should be positive in some areas of this. Cyclin D1 also can be a marker for high-grade endometrial stromal sarcomas. And then some endometrial stromal tumors will mark with a marker which we call BCOR or BCOR. There are two varieties of high-grade endometrial stromal sarcoma that have that marker. One is a BCOR fusion with another gene, and the other is a BCOR tandem repeat mutational change. Having said that, I'm not quite sure that this is, most of those tumors would not be cytokeratin positive with the CAM 5.2. So I don't know for sure that either supports us one way or the other. The other possibility here that I was thinking about is that of either a smooth muscle tumor, which has a very epithelioid appearance, or a perivascular epithelioid cell tumor or a PEComa. Now, PEComas and leiomyosarcomas we usually encounter in the uterus, not in the ovary, but they do occur there. In fact, I just pulled up one case here recently, which demonstrated perivascular epithelioid cell tumor in the ovary, and in their review of the other cases in this situation, they found about a half a dozen other primary ovarian tumors of this sort. So it's not an impossibility given the morphology that we are looking at, where you have these very pleomorphic cells and abundant cytoplasm, a little bit of ropiness to the cytoplasm. Now, we did an S100 stain that was negative, but that, again, is not the most sensitive example of perivascular epithelioid cell tumor. If I can show you an example here, let's see if this is the one. Oh, no, it's here. I'll show you this tumor here, which is a case from my slide files of a PEComa. And this one is maybe not as epithelioid as the example we've been looking at. Obviously, it's from the uterus, but it does have a fairly good amount of cytoplasm, as you can see here, and not the same degree of pleomorphism that we have in our case. But I had an earlier case which came from the CAP, which did have more of the kind of pleomorphism that we're seeing in our case here from Hanoi. And I think you can see there's a moderate degree of variability in the nuclei here. Again, quite a bit of cytoplasm in these cases. Now, one thing that is a challenge, of course, with these picomas is that you want to be able to demonstrate some degree of melanocytic as well as some degree of smooth muscle differentiation. And that can be somewhat variable, but it can be a little tricky. So, and just to illustrate that, here is the March'25 stain. Here you see the control tissue here, very bright red in these cells. And we use a red marker rather than the brown marker in cases where we think pigment might interfere with identifying the stain. So that's a useful thing to keep in mind, that you can do a red stain, counter stain, instead of a diaminobenzidine stain, which is going to be brown. But now, as you look at this tumor, you might say, oh, this looks negative, right? There's no staining. But in fact, as you come down lower, you see that there is some true cytoplasmic staining. Yes, it's weak. It's granular cytoplasmic staining in this case in a few cells. And this is sufficient to demonstrate melanocytic features. So you don't have to have the same degree of positivity that you would with melanoma, which was our control tissue, when you're looking for melanocytic differentiation in one of these perivascular epithelial cell tumors. Now, the same is true, but maybe less obviously or less subtle with HMB45, which is frequently used. And here you see the positive control, melanoma. But here you can see in our tissue, we do have some weak positive staining. It looks a little different. And again, it's a bit patchy, but clearly it's involving the cytoplasm of these cells. And you can highlight and see some of the pleomorphism. Now, these same principles apply when you're doing some of these stains for a sex cord stromal tumor, that some of those will be patchy or fairly weak in areas. So that's a possibility or something to think about as well. Now, I'm sure that you're going to ask me the question of, do these tumors stain with CAM 5.2? And that's a very good question. And the answer is rarely, but not never. We do have times when we can't explain why all the things that are staining are positive. We give it our best fit. Then if we have one stain that's a little bit off, we attribute it to that aberrant expression of something or another that makes that tumor unique. So I wouldn't totally say that the CAM 5.2 means that this can't be a pecoma. It makes it a little less likely. But short of that, I think we're going to be left calling this a high-grade malignant neoplasm of uncertain lineage. I don't think the surgeons or the oncologists like that. They like us to at least give them an idea of what kind of cancer they're treating. It gives them certainly a much better ability to predict what is going to be positive. So that to sort of summarize what the issues are here with a tumor like this is that it often takes 2 or sometimes 3 markers for a given lineage to be persuaded that it's going to be positive. So especially for sex cord stromal tumors, especially for some of these high-grade stromal sarcomas, or especially for here in the case of PCOMA, the possibility of a smooth muscle versus PCOMA type of neoplasm. So I think I sent you some of these suggestions, Dr. Lin. Were you able to do any of these additional stains in preparation? I can see you nodding your head. So do you want to share those results with us?
Yes, after that, I didn't spend anymore.
I haven't stained it yet. Okay. Okay. Well, that's okay. I think it kind of depends on what the patient can learn sometimes, and also on what the treatment options are for the patient. If this is confined to the ovary and it's a PCOMA, it may be just watchful waiting. If it's an endometrial stromal sarcoma of high grade, well, they probably would want to give some adjuvant treatment. So,
Yes, I don't think about the sarcoma sect. Yes.
yeah, so we have seen synovial sarcomas. We have seen other tumors in the abdomen, peritoneal cavity.
Yeah.
Not common. Fibrosarcomas, that sort of thing. They do occur on occasion. They're very uncommon. But so is PCOMA. So yeah, we've already moved it to the very uncommon side of things because of the absence of staining with anything that gives a lineage.
Yeah. Thank you. Thank you, Professor. Thank you
Well,
so much.
anyone else have any questions or comments?
And have a question from Dr. Thịnh in chat box.
Oh, okay. Yes, well, you're exactly right.
Yeah.
Being able to come up with a differential diagnosis has taken me about 30 years. So don't be discouraged if you're starting out and can't think of very many things that it could be. It does take a long time seeing a lot of things to be able to begin to figure out what else you've seen that looks like this.
Yeah.
Of course, that's one of the features that is being developed. We may look at maybe 5 or 10,000 cases a year, and so over a lifetime, maybe we'll accumulate, maybe 100,000 cases at the most that we've seen. But many of the new foundation models, the AI tools, the path chat, and other search tools are searching and looking at literally hundreds of thousands of cases. So these are going to be a big help for us later on when they become more widely available, lower cost, and easily linked in with our digital imaging systems. we can take a slide and say, hey, what do you see here? What else should I be considering? And they'll go through their uh, learning what they've learned and help us to figure out what it could be. We'll talk more about that next month when I come. That's a very exciting area of pathology, and I look forward to being with you next month and talking about some of these ideas.
Yeah. Professor, about this month, you come my department and we have a